Hello and welcome to Elemental TV. Today I'm joined by Nicola Irvin, consultant physician in acute and internal medicine and doctoral researcher in management science in the area of urgent care, and Chanjava Singer, research assistant, Department of Management Science at the University of Strathclyde. Today we'll be talking about the role of simulation software and how it proved an invaluable tool in adapting and then navigating the uncharted waters of managing emergency resourcing from the start of the COVID-19 pandemic. Nicola Chanjava consulted with NHS Lanarkshire on its COVID-19 planning, and key to this was to ensure that there was capacity available to handle all coronavirus patients as a priority, while also keeping as many traditional services running as possible. In moving to the next stage of managing the pandemic, we'll discuss the lessons learned, what new challenges face hospital management, and how simulation can support this. Nicola Chanjava, welcome to Elemental TV and thank you for joining me today.
Thanks very much.
Hello. So if I can start with you, please, Nicola. How did the strategic partnership between the University of Strathclyde and NHS Lanarkshire first come about? And can you give our audience some background to the programme that you worked on?
Yeah, so at the University of Strathclyde, the Department of Management Science, as other departments in the university, have quite a long established history of knowledge exchange between academia and also between industry and public sectors as well. We have a very specific health systems team within the business school and the management science department that have very recently started establishing a good relationship with quite a lot of different NHS providers, largely in Scotland because we're based in Glasgow, and in particular mostly to do with elective work, so things like emerging research and knowledge can be shared, particularly organisations who are maybe unable to do their own internal research and development. And NHS Lanarkshire approached the University of Strathclyde, I think it was last year, possibly the year before, to collaborate long term to the whole system. It predominantly looking at elective care in terms of improving efficiency, reducing waste, value-based health. But when the pandemic situation started to emerge in late February, early March, initially the team was asked to look at, well, if this is going to impact the UK, how much urgent care is going to be required, and as a result, how much elective activity are we going to have to put on hold, and which type of activity. But I think awareness around the potentially overwhelming impact became even more clear. That question was very, very swiftly focused into how much critical care capacity really are we going to have to need, because I think all hospitals at that point, certainly in early March, were aware of elective activity being cancelled, and now really just how big is this problem we're going to face. So we were asked to help NHS Lanarkshire predict what that problem is going to be within their population and how their own local acute resources were going to be able to cope with that, and what else, if anything, would need to be done in the face of those predictions.
And Nicola, you hail from a clinical frontline background. How critical was it to have this frontline expertise to make this project work, and what benefits did your understanding of that clinical environment bring to the project?
Having a clinician in particular, someone with almost a participatory clinical experience of working in urgent care was essential. But really what we're trying to capture is a very complicated, dynamic, evolving, adaptable environment. And it's like that on a daily basis in urgent care. When you throw a novel infectious pathogen into that with very limited understanding of how it behaves, not only how it behaves, but how we are going to behave, how the public behave, patients, staff, the system, and all of that, you have to have a clear understanding of what happens on a daily basis and how the system and how people respond when incidents happen. So as a clinician working in the front line and leading an urgent care unit myself, I've been involved in pandemic planning for H1N1, for major incidents. So you do have an understanding of how it responds, and also how things happen on a daily basis when capacity and demand fluctuate. It is important that someone like Chanjava and the other members of the team who are building this model have access to that information. And it can be quite time consuming initially. And it's sorry, I was going to say it's also important to understand that out of all of those things, you can't put everything into a model. You have to know what is important to include and where to include it. And I think because I work both with modelling and also with clinical medicine, it's easier for me to try and cut out a lot of the white noise. It's important to have an awareness of the simplicity that's required for some of these models, so that some of the more complicated elements of the healthcare system, which you might think have an impact on a daily basis, don't actually have an impact. To make sure things like that, the white noise isn't included, the model can be as streamlined as possible.
Okay, that's really interesting. So, Chandra, over to you for a second. Can you talk us through the process of creating a model for this type of project?
Yes, right. So to give a very brief background of simulation at first, as the name suggests, it's an approximate representation of any real life system.
Right.
Now, as far as computer simulation is concerned, they are basically mathematical or statistical models created using a computer, which kind of tries to best mimic a present real life scenario or a proposed scenario.
Yeah.
To then answer various what if questions and help decision makers make a very well informed decision.
How was the simulation used to assist the NHS in the capacity planning for the pandemic?
Right. So we kind of had a very flexible approach, and we engaged with the NHS Lanarkshire team on a fairly regular basis to kind of better inform our modeling process, and made changes to it as and when required.
Yep.
So this adaptive nature kind of helped us both build and refine our models from time to time.
Yeah.
For building the model, we had multiple meetings actually to understand how the frontline operation might really look like in order to build the primary structure of it, and then try to obtain data such as what bed capacity they had for all the hospitals under the health board. This data was fed into the simulate model, but this was not the only data. In addition to this, our team collected, analyzed, and made a spreadsheet model which was informed by data from other authentic sources and literature.
Right.
So this spreadsheet model churns out predicted demand figures on a week-by-week basis, considering a host of factors such as population profile, etc.
Right.
These numbers were also fed into the model, and then that simulation model gave us the maximum utilization of bed across all different categories on a week-by-week basis for the whole first wave of the pandemic.
Wow. And one of the things that has consistently impressed me throughout this pandemic is the speed at which the NHS and its partners have moved to react and problem solve. So, I mean, can you give us a sense, for some perspective of the timescales that you were working to here?
I mean, things were really tight. Anyone certainly living in the UK at the time, there was awareness, the beginning of the year of this infection that was happening predominantly in Asia.
Yeah.
All of a sudden, by the beginning of March, we started to think, well, it might kind of come over here. Okay, probably be okay. We had different strategies of herd immunity, and then lockdown. So by the time I think the whole country, and in particular policymakers, were aware that this could potentially be catastrophic, realistically, based on our understanding of international evidence, the experience of China, of Italy in particular, of Spain, we had about 2 weeks to give them some useful practical information from our modelling. We were very closely following what was happening in Italy and in Lombardy, and also following the general public behaviours in response to lockdown to see, well, of all the countries out there in the world that have experienced it, what has been their timeline? And which country most accurately represents what's going on in the UK in terms of the way the health system works, the population behaves, and the lockdown strategy that's been taken by the government. And as I was saying earlier about the clinical involvement, obviously trying to get a clinician involved in that who's also working at the same time it's impossible. So we weren't really able to access people other than by virtue through social media, through informal contacts and WhatsApp group. So being a clinician myself, I was able to keep my ear to the ground, speak to colleagues working across Scotland to get an idea of what was happening, how many patients are coming into you, what's the sense on the ground, are things starting to pick up? Are we looking like we're reaching peak? And is that starting to follow patterns that we're seeing elsewhere in the country?
The speed is just, it's kind of, it baffles me really, and it's so impressive. So a question for both of you. in turn, if that's okay. What do you think were the key successes of this project?
So I think once the executive team at Lanarkshire had set their key question, which was, what will be our critical care need? And do we currently have the resource, the capability to meet that? The fact that we were able to give them that information within 2 weeks and roughly 7 to 10 days before peak started, I think that was vital in helping them manage this pandemic. Now, there's still a lot of uncertainty involved in that, but that was their key question. They did a fantastic job of nailing what was important. So yeah, absolutely, giving them that information when in actual fact the advice that was being issued centrally was much more cautious than that, to be prepared for up to 5 times as much, which, you know, if you're going to increase your critical care capacity to more than 5 times your usual, there's significant staffing, costing and engineering and building implications in that would have been incredibly wasteful if they hadn't been needed. So the ability for us to say to them, look, this is what we're predicting, we're looking at the data as it's emerging locally and internationally every day, we're pretty confident about this is what you're going to have to face, and you've got sufficient capacity to deal with this. Now, but the other key success was, we have found some other areas though that you're going to need to look at. It's not just critical care. So we started looking at, you know, what's happening in urgent care. We were aware that other patients with emergency medical problems were presenting in smaller volumes, but the number of people who were presenting with suspected COVID, the turnaround time to the test result was significant. It was 2 days, and that was causing bottlenecks in the emergency department, which had potential for efficiency and safety in emergency care and in other areas of urgent care, such as acute medical units. We were also able to pick up things like length of stay. So we were predicting more patients with non-severe as well as severe disease coming into hospital, being unable to discharge back safely. So while critical care was important, we were saying, yes, it is important, but your other inpatient resources are predicted to be impacted. So you need to have a plan in place for this.
Absolutely.
And finally, as we started to predict community cases reducing, and we saw that in the data as we analysed it every day, we could see ongoing infection in the hospital. So we were able to point out to them very early on, there are some potential issues about infection being transmitted within the hospital that you need to start looking at. So it wasn't just critical care. We were able, with what is essentially quite a simple model, give them so much more information to help them deal with this pandemic in a much more practical way. Certainly, you know, we have given them much more information months in advance, but that's just not the nature of this kind of situation. But giving somebody information a day in advance or a week in advance can be invaluable.
Oh, absolutely. I mean, it just seems such it can drive such efficiency, can't it, in terms of that planning. And for you, Chandra, what were the key elements of success from your point of view?
As Nicola mentioned very well, that we were able to pick up other things other than critical care beds as well. And, those were the things that were acknowledged in the best possible way by the NHS Lanarkshire team as well. And due to these successes, actually, we are also in some kind of discussion as to how could we provide more support using this simulation tool to better cope with the demand during the next possible peak, where the things are already, NHS is already under pressure during the winter months.
It is, isn't it? It's that's definitely something to consider. So, Nicola, the approach clearly delivered some really powerful and valuable insights for NHS Lanarkshire. What piece of advice would you give to other NHS organisations as they're planning for a potential second wave of the pandemic?
I would say to do what NHS Lanarkshire did, which is to recognise that this is something that is not just a clinical problem. This is not just a question of critical care. This is a complex situation. It is also pretty difficult to predict. So having what we describe as a triumvirate of executive expertise, clinical expertise, and modelling expertise in the room early on to try and look at how you can predict what's going to happen. And in particular, using your own data, using your own evidence. What is the situation in your population? What is the situation in your hospital? How is that evolving every day? And also what's happening in other parts of the country or other parts of the world that you can explore, that you can start to model your response on. That's certainly what we did, but it wouldn't have been possible without having those three key components. So the clinician who understands the dynamic situation and the behaviours of the organisation, the behaviours of the system, the modeller who's able to interpret that very sort of nuanced dynamic environment and to simplify and abstract into a model that can be usefully predictive, and also an executive team who have the authority to act on those predictions, but also the authority to give you access to data which, you know, could be quite confidential, that people might have reservations about sharing with, and that executive team member as well is vital in setting the key question. There can be a desire to answer so many questions at once. So one of the I think a vital piece of advice for anyone looking at this is set yourself one or two key priorities. And I think the executive team are going to be the people to know exactly what that is, because as a clinician, I might have a different priority. Someone who's involved in planning the beds might have a different priority, but your executive team member knows what's best for the whole hospital and that whole population.
Yeah, it's funny that it's been quite a common theme throughout this as we've looked at success stories, that it's been that collaboration and having those multiple stakeholders involved very, very early on. You know, sort of the aces in their places, I guess. So, Nicola, that's really interesting. What information did you actually use to validate this model?
Well, yeah, thank you. Validation is a key part of any modelling process. You want to make sure that you've captured the process that you are modelling, the environment, the disease, the activity. And crucial to this was daily information from the organisation. They provided us with their the numbers of patients attending, the number of positive tests, patients in intensive care, patients in emergency care. But we also combined that with evidence that was emerging internationally and nationally. There was an intensive care audit that was coming out of London, being updated every week. That was crucial to look at how length of stay was impacting, because length of stay is a really important aspect of modelling a discrete event simulation, which is another reason I think why it was so successful in this case compared with some of the earlier static epidemiological models that came out centrally from the government. We were able to constantly update our model using discrete event simulation, using data from the local organisation, from the intensive care audit, the European Centre for Disease Control. All of these areas were freely accessible data that you could then use to apply and say, okay, well, is my model behaving the way that real life is behaving? And when we compare that with what we're seeing on the ground every day in NHS Lanarkshire, is that working? And that required validation, sometimes twice a week, in order to be accurate and give that information to the organisation that was going to be useful for them going forward.
Yeah, that's fantastic. So last question, this is a great example of how digital simulation can be used to assist healthcare management. What other applications do you think it might be suitable for, and what do you think the future looks like for that?
To be honest, I struggle in healthcare to see applications where it wouldn't be useful. What I think has been particularly enlightening for me, so moving from a clinical background into academia, looking at management science, operational research, is just how unaware I was that these tools were in place, that things like this kind of software, this methodology could be used to help us organise and design and deliver services in a much more effective way, not just efficiency, because I understand there's a need for efficiency, but there's also, as a clinician, there's a need for effectiveness. And these models allow us to, well, depending on getting the right model, allows you to create almost a virtual experimental laboratory where you can say, okay, I think if I designed my system in this way, these are the patient outcomes that I could see, these are the efficiency outcomes that I could see, this is the staffing outcomes that I could see. But to actually deliver that as a trial would be cumbersome, would take a long time, would be expensive. There'd be a lot of opposition to that. But to be able to do that in a virtual environment, to see, well, what would be the outcomes? Could I reduce variation? Could I improve patient experience? So I think the possibilities are limitless. At the moment, it seems to be focused very much on elective care. And I understand why that is. Elective care is, by definition, much easier to plan and predict. I think there are significant avenues for exploration in urgent care, in particular the service delivery of urgent care and things like urgent ambulatory care. My own research is involved in urgent care management and how we model that to be more effective. So this definitely is and it would be great to see more clinical teams, not just doctors, but nurses, other kind of allied health professionals getting involved with their organisation to look at this, not just from a research perspective, but from a daily service development.
Absolutely. Yeah.
And the availability is there from academia. I mean, I think, again, my experience in not understanding that these specialists exist, operational researchers, management science, that's not something I was aware of doing a medical degree. But now I'm aware that universities across the country, but those do have these people who are more than happy to collaborate with academia to help them. Tools would be applicable and possibly not for the question that they're asking. So I would definitely urge people to get in touch with their local university to collaborate with them to get more information.
Yeah, that's a definite call to arms there, if ever I heard one. Thank you so much. So, I mean, we're out of time now, but Nicola Chandrava, thank you so much for joining me today. Thank you to all our viewers for watching, and remember, you can see more from our COVID-19 special reports by visiting weareelemental.tv, and remember to follow us on Twitter @eHealthTV. Bye for now.